My name is Melanie Dizon. I'm the Director of Education and Research at the Davis-Phinney Foundation, and I'm very excited to be here today for understanding the role of trust and health disparities in Parkinson's and in the healthcare world. So today we have our moderator. He is one of our board members, a huge friend of the Davis-Phinney Foundation, one of the founders of Dance for PD, David Leventhal. Thank you so much for being here, David.
My pleasure, Mel. Great to be with you.
Great. And we have Dr. Saadi and Dr. Wilkins, who are going to be here to talk about trust. These are experts in this field. We're super excited to have them on. Thank you for being here, both of you.
Thanks so much, Mel. And again, it's really a great pleasure and an honor to be here and to help moderate another in our series of conversations around a very critical issue. And this is an issue that we started talking about last year at the Davis-Phinney Foundation publicly. We've been talking about it for a while before then. But I'm thrilled to have the honor to listen to and to learn from Dr. Saadi and Dr. Wilkins today. And I'm really here to support them and to moderate this conversation. And then in the second half of today to help bring some of your questions to them so that they can respond. So just a brief overview of how today's going to work. We're going to very quickly transition into a conversation between our experts. I will step back for that point. We'll give them about half an hour to speak, and then we'll come back with some of your questions. And we'll try to address as many of those questions as we can. We will encourage you to forward those questions via chat, and we will try to forward those questions to our experts today. Just a reminder that we will be sending video and audio recordings of today's session to you. So if you miss any part of it or love it so much you want to watch it again, or forward it to anyone in your community who you think might be interested in this topic, we would love for you to do that, and we will send you the resources to do that. Today's topic is an enormously important one. It comes up in every conversation that we've had about health disparities, and the topic today is trust. So what do we really mean by trust? What do we mean by trusting your physician? What do we mean by trusting the medical system to make good decisions on our behalf? In this conversation, Dr. Saadi and Dr. Wilkins will examine this concept of trust, what we mean when we talk about trust, and how trust is really necessary. It's one of the first cornerstones that we need to understand to address health disparities. To really engage in this conversation, our friends at the Foundation have asked two experts to join us. Dr. Consuelo Wilkins is the Vice President for Health Equity and a Professor of Medicine at the Vanderbilt University Medical Center. She's an expert in this area, and we're honored that she's with us today. Dr. Saadi, also an expert in this area, is a general academic neurologist at Massachusetts General Hospital and instructor of neurology at Harvard Medical School. She's also associate director of the MGH Asylum Clinic. Her research is focused on health disparities and social and structural determinants of health among racial and ethnic minorities, immigrants, and refugees. Without further ado, I'm going to welcome you both and let you take it from here. It is a great pleasure to be able to hear you speak and to learn from you. So Dr. Saadi and Dr. Wilkins, thank you so much for being here.
Thank you. Thanks so much, David. I'm so excited to be here. And I have to say, I'm so excited to be on this webinar with Dr. Wilkins, who's sort of a superstar, and I am junior faculty. So it's just really an honor to participate in this conversation.
I'm honored. I mean, you already shared that your daughter regards you as a queen, and I lost that status a long time ago. So you're right now more honorable than I am. So.
For the context of people who weren't here for the earlier conversation, my daughter's also 2 years old. So that context.
It's very important.
Yeah. Well, I think that, one of the things that comes up a lot, and even when I have the publications have written about this, is that you hear trust, you hear mistrust, you hear distrust. I sort of wanted to just and I'd love to hear from you how you conceptualize them. You know, I think to me, they're sort of different things, and sometimes people think about them as being on a spectrum, but yeah, I would love your thoughts just starting off the bat, and then I can sort of feed off of that. But that's something I hear a lot of people, because there's all this different lingo around that. And so just beginning with definitions and differences.
Yes, well, a great question. I mean, I think first we should acknowledge that the word trust is very complex. You know, it has many different dimensions and domains, and it's relational as far as, you know, if you're in a setting of, you know, healthcare delivery or a relationship, personal relationship that's not, you know, in the healthcare setting, it puts people, or requires actually, that people are often in this vulnerable position. But I think that, you know, trust, you know, imagining that you have some reliable belief and the reliability, the validity, the competence of something or someone is really how I start to think about trust. And I do think it's important to recognize that distrust or mistrust isn't necessarily on the continuum of trust. So on one side there's trusting, and the other side is distrusting. That's actually not quite correct. You know, you can have high or low trust, more or less trust, and you can also have distrust, which is really, you know, this more of a heightened sense of fear and skepticism that we are seeing a lot right now as we see populations that are marginalized and minoritized and have been abused or exploited in the past. And so there's this fear that's sort of built into, I wasn't treated fairly in the past, or people like me were harmed. And so part of that distrust actually is a defense mechanism and might be expected, so that, you know, it's a way to protect yourselves from, you know, not being harmed again. And so again, it's, you know, it has oftentimes less to do with whether or not you as a neurologist is competent, well-trained, experienced, and all of those things. It's more about, you know, should I believe that people like me won't be harmed, or that we'll be treated fairly?
Yeah, I think that I was just sort of jotting down the things that I thought really resonated with me. One of them was that you sort of said it's a relational process. And so really highlighting to me that in any relationship, right, whether it's with a child or with a parent or with anyone, there's sort of that, you know, there's like the belief component, but then there's also the constant active process component. So it's not just a belief, but because it's a relationship, we have to think of it as constantly ongoing, and that it really is like this action or process rather than just sort of like an attitude or a belief, or maybe it's a combination of both. So that was one of the things you saying that I think is like really helpful. And then the other thing I think, to your point about that it's a coping mechanism, made me think about how, and I think that's even with the vaccine, it's part of the frustration for me of hearing it, is that we actually need to normalize this lack of trust, that it's like really normal. Like, it is normal. We want people to be critical. You don't want people to do things blindly. It's good for people to ask questions. Like, even like those are things we want to encourage. And so part of it is also that, you know, the construct of like, this is abnormal. It's like, no, this is like a very normal, whether it's coping based on prior experiences, experienced personally or from like a community we belong to, but that is sort of a normal coping or reality for people.
Yeah, and I think it's incredibly important, the aspect that you just mentioned about validating people's, you know, trust, lack of trust, or distrust based on their personal beliefs, their experiences, the group experiences, that we, you know, one of the most frustrating, I think, things that I've seen, especially when we talk about all the information and misinformation, disinformation related to the vaccine, is that we sort of paint this picture of people being abnormal or really ridiculing people who
there's something wrong with them.
Yes, I'm like, why don't you believe this? Like, I can't, why would you not trust this? As opposed to having the humility to say, I can imagine why this person, these people might not believe or trust or find this this information reliable.
Yeah, I think the other part, like when you, if you're saying that it's sort of not necessarily on a continuum, is that those feelings can coexist at the same time. So that you can trust this one physician at your community health center because you've been seeing this one person for many years, and that relationship has been sort of forged and nurtured over years. But then you go to a new person or you go to a new health center, and that those feelings and can just are not mutually exclusive, and it can be with one person but not with another person, or maybe you can trust physicians but you don't trust researchers, right? That it's sort of, there's those differences there.
Yeah, that's one of the most complex things I think for people to try and understand, that a person can have a high level of distrust at baseline, like, the skepticism and fear about the healthcare environment, about research, but they can still develop a high level of trust in a provider. And I'm sure you've seen that a lot in your work with, being able to demonstrate to people that you're providing care for or you're involving in research, that you genuinely care about their well-being, their interests, you're willing to understand their needs and their priorities. And so they develop this trust with you that's not necessarily transferable to everybody at MGH. Or for me, everybody at Vanderbilt, or at whatever setting you're in, but they're able to believe enough in you and find you reliable and really trustworthy. So that aspect of, a lot of times too, we're focusing so much on, how do we build trust and how do we make people more trusting, as opposed to, how are we more trustworthy. And I think to really even try and get to this distrust piece, we're talking about having to change systems and institutions to being more trustworthy. And that's a huge step. A lot of work would have to be done for that.
Yeah. I'd love for you to sort of talk through like examples of how, so those are two separate things of like health systems building trust, and then on the individual level building trust. Maybe we can start with the individual level because I think that's a little easier. But I was thinking the example that came to mind was just like in our work with asylum seekers. And so sometimes people have been in situations, whether it's in detention, prison, or where physicians have watched sort of horrible things happen to them and have condoned horrible things happen to them. And again, this is not just in other countries, like this happens in immigration detention where physicians are sort of watching horrible things happen. And so when I am having those interactions, I always start with a acknowledgement of negative experiences and to sort of say, look, like I understand that you might have faced this, or like, but I just want to reassure you, like, this is where I'm starting and I'm here and committed to like building this relationship with you. And so I usually, that's one of the, if it's like quote unquote strategies that I use, but I think it needs to be part of the picture of like acknowledging and validating that that's normal and it's fine. I'd love to hear your thoughts of other strategies or sort of, tips or, in terms of building that trust on an individual level.
You already took the best answers. You have to validate people's feelings, experiences, and let them know in a respectful way that you see them, you hear them, even if you can't possibly imagine what those experiences were. Sometimes you can, sometimes you've had those experiences yourself, but sometimes you haven't. But being able to actually acknowledge that and really allow people to understand that you accept those things that they say as their truth, and you believe them, and you want to learn, and you want to hear, and you all of those things. And so, if you really think about it, part of that is also that you're trusting them. So if you want to be trustworthy, are you trusting them? Are you trusting that, their lived experiences need to be valued in the same way that other people's do, and that they need to be considered? And, the way that they approach their health and well-being might be different from what we've learned or been taught as physicians. So I think, all of those things are really important. And, a piece of that is being, empathetic. And another piece of that is humility, which is, again, assuming that the person in front of you is as important as you are and everyone else. And I think people need to be able to get that feeling from you. And I don't want to go into politics really, but just imagine the amount of mistrust or lack of trust just in general in the political space now, and people really trusting individuals or organizations that make them feel validated and seen. That's a broader concept of people see them, understand them, and give some validation or value to the voices that mean. I think in the setting of the clinical setting, as well as the biomedical research setting, effectively communicating with people is really, really critical to being trustworthy and demonstrating that you're trustworthy. Are you again understanding how a person communicates, what language, understanding cultural nuances, or at least trying to understand those, or making space for people to tell you how, if you get something wrong, and how to actually best communicate with people. I think that's something that's really practical, that I think we could spend more time focusing on.
One of the, when you're like talking and I'm thinking about just like patients and stories, one of the things that you said, I think that's actually a really huge gem that we don't talk about enough, of how much sort of, it's like, do we trust them? And I was just writing it down because I don't think we realize how much it's like baked into our even education not to trust patients. The person I thought of when you were saying that was, I had asked, and this is a patient, about how much alcohol they consume in a week, and he said, doc, like I don't even feel like if I know you guys are taught, if I told you a number, you're going to just multiply it by 3, and so I'm afraid to even give you a number because I don't want you to multiply it by 3. And it was just like this moment for me that I was like, wow, yes, that's like, even at that, when I was taught that, and I don't, maybe it's changed now, but I didn't graduate, like the past decade, but that was part of our teaching, was like, oh, the patient's going to tell you this, but you should multiply it. So it's like, even it's so baked into of like, do we really trust them? So I thought that again, in that encounter was something that took me aback. But then even just when you were saying that, was just like, well, are we trusting them? Or when they say something, do we actually believe it? Or are we just expecting, being like, well, I'm the one that you should be trusting, and not sort of giving people that in return. So that, I think, the other thing, which I mostly just I'd love your thoughts on, because this is something I struggle with. If you have had personal experiences that sort of map along with what someone might be experiencing, seeing, do you talk about that? Do you bring that into the encounter?
It depends. I mean, I think I try to be careful not to decenter the person in front of me. And sometimes when in attempts to show empathy or try and validate, we introduce these situations or our personal experiences, and the person doesn't quite see them the same, and actually detract from that. And so I'm cautious and careful not to do that, but also that I don't want to take up more time to talk about myself, if possible, because I think, especially in the clinical setting, we often have so little time to do that. But when there are those opportunities to let people know how we're alike, I think that's a good thing. Sometimes that's more of a casual conversation, like we both have kids. We have some shared experience or things that we like, and I think that's maybe a safer way so that it doesn't sort of detract from other people there. So I'll give you an example of a quick example. So I was having this conversation with some medical students recently, and we were talking, and then one of the students, she gave this beautiful presentation about people who are LGBTQIA, sexual and gender minorities, and sort of affirming how specifically how transgender people might feel being referred to by the wrong pronoun. And her example was about how people mispronounce her name and how that made her feel. And it was, I think she was really attempting to make that connection, which on the surface might seem similar. My name is being mispronounced, and so I understand how you feel with not being called by the right pronoun. Is again decentering that experience, which from the standpoint of a transgender person is likely very different. Like, no, you cannot possibly think that your name being mispronounced is the same as people not accepting the gender that I identify as, and how I'm marginalized because of that.
Yeah, I think that's a really good example, and I've definitely, I think that can happen. I've been in interactions where that has happened to me, and in your mind, you're like, no, you don't know. This is not like your example. Do you think, I know one of the, so we've talked sort of the strategies of building on an individual level, and I had flagged it for us to go talk about the health system piece, because I think that that's a really big part of it. And one of my sort of fellowship baby projects was around, like, I create a toolkit of like creating immigrant-friendly health systems and sort of what that means. And so I think about that a lot, but where just starting with that, like, how do you begin to think about that? That's sort of different from the individual level, and then thinking about it at the organizational level.
Yeah, I mean, I think that if we're going to address issues like trust at the organizational level, the institutional level, and the healthcare enterprise system as a level, then we have to start to think about policy issues, and policy with a capital P and a lowercase p. So what are the practices and policies that need to change as well. So specifically, if we're thinking about people who have Parkinson's disease and who may or may not have had failed treatments in the past. Their diagnostic tests have been less accurate. They're sort of bouncing around from clinician to clinician, and thinking about how they have to try and access the system, and might feel marginalized or disenfranchised for different reasons. Then what kinds of systems level changes might actually help build trust among this group of people or their families, perhaps that's legislation or policies, or even within health systems changes that would allow for the visits to be extended. So a standard visit for a person with Parkinson's disease who might have difficulty with ambulation and difficulty with speech, and really the expectation that these people are being rushed through an exam or a visit in a short period of time, that there are new codes in the billing system that would really allow for more appropriate time for people to actually get care, and allow for their caregivers to more easily get information about their health and management. So I mean, I think those kind of broader, what can we do, what kind of oversight programs do we need for a research program that's focused on a specific disease to make sure that people who are racial and ethnic minorities with Parkinson's disease are thought of differently, have opportunities to participate, that their needs are met, and those sorts of things, so that's sort of standardized in some way.
I think the point about the length of time at the clinic visits is such a good one, because I mean, even if you layer sort of limited English proficiency on top of that, right? And yet we're expected to see someone in that exact same period of time. So naturally, that means that person is getting less time spent with them, right? Because if you're expected to see them in the same time period, but there is that extra time that factors in to interpreter use, and then if they do have neurologic illness, that makes things slower in terms of the encounter. Yeah, that is like a structural thing that needs to be thought about being shifted to.
Let's imagine that in the setting also of telehealth. So right now there's so much of a push for telehealth and the increased utilization, and I think so I've been really excited that we've been able to push through bills and policies that people thought just impossible before.
Yeah, like the audio visits. Yeah,
we can get them done, but still the connection for a person with telehealth who needs an interpreter is very complex. Patching in another person into the visit requires a lot more work and thought and all of those things. And now let's imagine that person has Parkinson's and has a tremor and might have difficulty using the computer. And how does that work? What additional accommodations, considerations, practices, policy changes are needed to actually allow people to fully utilize telehealth? And not to mention that there's certainly those issues around telehealth that have to do with access, broadband access, the kind of device you have, because having a telehealth visit with a computer on a table is very different than having a.
And if it's on your phone and you're in a car, yeah.
Right. Yeah,
or between shifts, yeah.
We've seen those before. Like, that's the only quiet place for people.
I had someone was in their bathroom because they were like, there's just way too much family and they wanted to discuss something privately, and they were just like in their bathroom for this visit, and it was like this tiny little. It was just. Yeah, it's a very different experience.
Or you're in a rural community, or even in an urban environment, you don't have Wi-Fi at home, and you're in a parking lot using the McDonald's or Starbucks, Wi-Fi to do your
work. Yeah. The other bit that, and I'm glad you sort of, that I was thinking about bringing it to thinking about some of my PD patients, was also that there is the trust beyond the individual, right? It's really with the whole family, and that, or there are multiple people in the family, or that there might be a spouse or daughter, or that there'll be people who have their own sort of sets of beliefs and issues, and that needing to think about it even beyond right, we think about the individual level, but even in the individual level, there's like a family unit, right, that is thinking about that. Yeah, so that I don't know if you have any thoughts about that or challenges that have come up, but I think that comes up a lot, particularly with neurologic diseases, because, we have to, a lot of times people rely on their families to be advocates for them.
Yeah, I mean, I think, we talk about trust being complex with an individual.
Yeah.
And
and then layering that on top.
Organization, and then the family, depending on how many children or grandchildren or others are involved in the care center, like and that's why I'm cautious too when we sort of think about, there's some groups that are have higher levels of distrust at baseline, that fear, skepticism. We know those are groups that are marginalized, minoritized, limited English proficiency, limited resources. Like those groups of people tend to have more distrust and less trust. But every individual is different. You can't, it doesn't translate across the entire group. And within any particular family, you're going to see varying levels of trust, as well as ability to advocate and understand and sort of navigate the health system. So you have to certainly add all of those things into which, again, this is a very complex setting, being in healthcare. I would say that certainly for some groups and cultures, healthcare decisions are more likely to be made as a family. And so, talking about Parkinson's, more common in older adults, and the family dynamics and cultures involved in decision making also make it more complex, as I'm sure you've seen a ton.
Yeah. And I think we're going to be transitioning to the Q&A soon, but I thought one aspect we've sort of talked about, like strategies of nurturing trust, but maybe also being explicit about what causes trust to break down. So I think you already kind of, some of it has sort of already been woven into and out of the conversation, but one of the things that you brought up already in terms of like effective communication, as part of effective communication is really giving as like full information. So that includes, it's like as basic as like talking through medication side effects, talking through like potential places where things might fail, right? And being explicit that like this could happen, so that it doesn't blindside people later and be like, well, this person never told me, right? And so then that feeds into ideas that, oh, well, this person wasn't sort of giving me the full information, or so yeah. Sorry, that might have been something, but what are your, I'm always saying that probably the easiest things first, and then I'm like, Dr. Wilkins,
yeah,
you're up.
You're like, you can do this, like, now what else?
Yeah.
Well, I mean, I do think that I'll hone in on maybe the medications and treatment. I think that risk and harm, I don't think in general we do the best job of sort of laying out on the table of what people should expect when we are managing especially conditions as complex and variable as Parkinson's disease. What exactly should you expect with this specific treatment? What are the harms? What are the unintended consequences? And then also, how do people know that we're there for them? How can they trust us? What are we doing that is demonstrating our trustworthiness? And so back to that communications piece, do people know what to do when things don't go as planned or as expected? And how do they reach us? And will we be able to communicate effectively with them? And will we validate their experiences as opposed to saying, that's never happened before. That seems strange. I'm not sure. Did you take it right? Or so I think there's certainly some things that we could be doing or we should be doing. Again, that's really focusing on our trustworthiness.
Well, I think that anticipatory sort of guidance is like bold, italicized, like highlighted, because I think I'm just thinking about even, our patient portal of someone sending, and when I do that, it's like being explicit that like I might not be able to get back to that message, within like right away, like that's not how that system works. And so being able to communicate sort of this is what to expect through these different routes. So whether how to call if you need, or this is sort of the length of time that it might take, or this is just sort of that anticipatory guidance. So whether it's with just like navigating the healthcare or interactions with us, or, just like, navigating or treatments, sort of the course of disease. I think there's just all these different factors, right? I think in the research process, people come and we sit them through sort of multiple sessions, but we typically don't. It's not as rigorous in the clinical setting often because we're not required to, right? So we don't go through that stuff in as much detail.
Yeah. Well, I know we're transitioning, but I would just say, we didn't really talk about privacy, but I think it's especially, thinking about patient portals and how people use them and communicate with each other, like that expectation of privacy and as well as confidentiality. And people are very different in their and how they view risk of privacy. And so again, people who are from these groups that have been marginalized and exploited in the past, their risk perceptions around privacy can be very different.
We had that come up with our patient, a lot of our immigrant populations, where people would be like, well, who's someone going to be listening in on the conversation? Is it being recorded? Who's it being shared with? Are you sharing it? And so we ended up developing a script that was sort of included by folks who would be signing up people for the patient portal to say, like, here's how you sign up. And then it was part of that introductory script to say, like, this is, confidential, like HIPAA's, whatever, to sort of give that upfront. But I think that is really key. And I see, David, you've popped up now, and are we transitioning to the Q&A? Is this the moment?
We are gently, subtly transitioning in. Just we have a lot of great questions, and I could listen to the two of you speak for a long time, but I want to make sure that we do address some of the questions that have come up, and so I'm going to circle in if this feels like a good time for the two of you to do that. Yeah. Okay. I want to start actually in the area of provider trust. So one of the questions that came in, which you touched on a little bit, is this issue of I see my movement disorder specialist every 6 months for a very short time. The visit feels really rushed. How do I make the most of that visit in terms of trust? And also, part two is, who else can I lean on to kind of help me with that relationship? Who else in my care team might I trust more and therefore build a stronger relationship if I'm only seeing my neurologist for a short time every 6 months?
Altaf, I'm going to let you have it.
Well, I have to say, and this is very, because I practice both at a community health center and at sort of the main campus. And at the community health center, we're so lucky because we have community health workers that I can refer patients to. And it is so good that I've been pushing our main campus, being like, we need a community health worker, like someone to help people navigate through. And we just got funding for to do a pilot thing, which was exciting. But I think that sort of goes into this piece about, one, if you know that that's something that's potentially an option, asking about it. But for those of us who are in roles where we can be advocating for like navigators, patient navigators, community health workers, promotoras, like these are positions or roles that can really help, and they've shown to make a difference in a whole host of neurologic and non-neurologic illnesses. So I think, so in terms of what I'll say, like what I tell my own patients, and this is challenging because I'm saying this while acknowledging that I saw someone this morning who, when I asked about family, responded, I have no one. But I always start with, like, can we loop in other folks in the family that can also help? And trying to sort of myself being proactive in building relationships with the primary care doctor, with other doctors who might be part of the team, and saying, look, we're part of the team. If you can't get a hold of one of us, you know, touch base with the other person. But I say that recognizing that there's a lot of complications in that. And that's why we need sort of structural community organizational responses like community health workers or peer navigate, you know, patient navigators to sort of fill in those gaps for folks.
Yeah, and if I could just add, I think, you know, just pointing out that that's a policy issue, especially in places like, you know, in Nashville and Tennessee, we don't have a reimbursement model.
Yeah.
Or
like who's paying for that?
Who's paying for it? They're not community health workers. We don't have an association that actually can certify them. And so, you know, we have found them to be incredibly helpful. I mean, they are amazing to have, you know, peer educators, navigators, community health workers, promotoras. Those individuals are a tremendous asset, but we, in many places, we don't have well-developed ways of actually reimbursing for their services, training them, and those sorts of things. I also think, as far as the, you know, the interval between visits, you know, we need a way to easily get sort of objective information into specialists, along with, not to say that your subjective, your feelings, your symptoms aren't as important, but, you know, what's the trigger to, when you saw your movement disorder specialist, if they said, we'll see you in 6 months, you know, what's the trigger to get you in sooner? And how can we make sure that that's an easy process or step or way to get that information in, so that you can then get into what is in most places a very limited number of movement disorder specialists.
Yeah. But I think that goes into the anticipatory guidance. That was what we're talking about, right? Like that, it needs to be part of the conversation of, like, this is how you'd get in touch with me. This is how you'd get in touch with this other person. And these are the reasons why that you would come to me, as opposed to, you know, your primary care doctor or whatever.
Well, and that dovetails with another question. That is, if you have one movement disorder specialist in your community, it can feel like you don't have another option, even if you don't fully trust them. So there's a question about what you can do to change or advocate for yourself if this is your situation, which probably is requires some of the same skills as building trust in those very short visits. So I mean, you've touched on this a little bit, but what are some strategies, aside from reaching out to other providers or support systems in the network? What are some strategies that you recommend for kind of self-advocacy and kind of standing your ground and speaking up for yourself in those situations where you really don't have other options?
Yeah, you know, I think that's a really challenging one, especially when you're in a setting with limited specialists. So, you know, where else do you go, and how else can you get access to someone? Is there a support group or organization that can help support and advocate for you, or link to other resources? You know, getting back to the telehealth, I think we will see more opportunities for people to link to specialists, subspecialists in other areas remotely now with telehealth. That's certainly something that we are pursuing at Vanderbilt, not specifically for Parkinson's disease, but just, you know, we're a regional provider. And so certainly, you know, we have many patients who are in bordering states who come to Nashville to get their specialty care. And we've had to sort of work through some of those issues around legal issues around, you know, if you live in Kentucky or West Virginia, and you usually come to Vanderbilt, then, you know, how can we actually link you to those telehealth visits when you're at your home. That's more complicated perhaps than people want to know. But I think that there'll be more and more of those opportunities for people to connect to virtual care, which is certainly not always ideal, but maybe another option.
One of the things I was thinking about when you asked that question, David, was that, and this is something that I think requires also advocacy within professional organizations, but sort of regional or professional society conferences can be a really great way to get information. And that's something that I have been trying to push. And I know that for certain organizations, they are, or parts of are being opened up, or they have conferences for people who are, have a particular disease or disorder. And so they're able to sort of participate in the knowledge and make those connections. And I know, so the American Academy of Neurology, and again, this is within, I think, the past 5-6 years that it happened, but there's an annual meeting that happens every year, sort of before physically, but now virtually. But one of the things based on a lot of pushing, sort of both from patients, but as well as sort of physician advocacy, was now the day before they do this brain health thing where they actually have physicians that you can rotate through and ask questions. And I've participated in them. So it's you can talk and even just get ideas about your particular, so I think the professional organizations can be one way in terms of potential for future advocacy and trying to open up more resources for people. And I hope sort of making even continuing knowledge and trials and research more accessible to everyone. But I think that that's another potential venue to push for more access.
Thank you. One of our attendees wanted to bring up the issue of censoring symptoms, and had spoken to someone recently who said they no longer discuss their depression because they saw what their doctor had written in the chart. And I guess this gets into something we didn't talk about a lot, is this issue of privacy and this issue of, feeling comfortable providing your healthcare professional with information they need to support you and to help you, but feeling that that information is going to be used wisely and without judgment. So I know that's a very complicated question, but I'm gonna open it up to the two of you to unpack for us a little bit.
Yeah, I mean, I think we saw so much of this when we first started making the charts, the notes open to patients. Obviously, you could get your records, a hard copy of records, but now you can just go in and get them and see the notes, and people were really taken aback about whether how their physicians or clinicians talked about them and described them in these notes. And I think it really is something that I, as a physician, certainly had to be more conscious of. How we're taught often is we really talk about people sometimes as problem lists, and not as, and don't bring in the more human side aspects of when we're talking about them, the medical lingo and lots of acronyms and those things that can be confusing. But certainly, David, as you pointed out, that judgment piece of how we're considering information, how we're using it, what conclusions we're coming to based on symptoms that people report, is something that we do have to be more cognizant of. But also, I think in addition to the privacy piece, we have to talk about the respect piece. So respect is tightly linked to trust, and people, if people don't find that you're respecting them, or you're respecting their values and views, or then they're certainly not going to trust you. I do think that considering how how you share information with your provider, and being able to say, I completed the questions about, I answered the questions about depression. What are you going to do with it? What does it mean? If you feel like you can have that conversation with the provider to say, I read this and I just want to make sure I understand what this means in the notes, and how it's being used, and what your perceptions are, or how that information is being used, which again can be really, really complex.
I don't have much to add. I think that if someone feels empowered enough, that asking should happen. So, and I've had patients who have read my notes and who have said, written back and said, look, I read this thing and I actually wanted to say, like, this thing you documented was incorrect, or it made me think about this additional thing, and then I've gone back and sort of addended or changed the note. I do very much, so part of our immigrant-friendly health systems toolkit is around like not documenting immigration status in medical records, for example. So that is a huge piece. I do think that a lot of times physicians, any clinician, we don't realize that things that get on medical records stick with people forever, and then there's sort of just gets carried on. And so I think that we need to do a better job of also including these conversations in our training and sort of understanding the ramifications of what we put in people's charts. So in the context of immigration, for example, like someone, our immigration system is so complex that someone could be undocumented and then 10 years later could be a citizen. And like, that's how it works, because people's immigration status is very complicated, but you put something in someone's chart and it sticks, and it doesn't sort of acknowledge the reality that, something might have changed. I see this also come up a lot around substance use, where people are constant, I had one encounter where it just sort of broke my heart, where this person has not been using for more than 10 years, but it's like all of his chart, and he just literally just felt like he needed to keep being like, this was in my past, I promise this was in my past. And I'm just like, okay, got it. But I think it, those things stay in people's charts. So I think there's one that we really need to do a better job of talking about the ramifications, both from like a stigma perspective, and then the piece of like what happens when that information gets in there. But from the patient end, I say, like, if you feel empowered enough, like, take it up, like, bring it up to,
And sometimes it's easier to bring it up in a note, in an email, a note through page portal, because just to say, I noticed this in the chart and I'd like to discuss it, or I think you don't have a full understanding of my symptoms and I'd like to share more about that, or your perception is different than mine, and sort of starting it that way, just to bring the attention to the provider so they can be prepared to discuss it, and maybe it's a little bit easier in person.
Yeah,
they have that in advance.
You both work with medical students in your daily life. How much is this issue of trust brought into medical training, sort of the next generation of physicians? And the second part of that is, how do we also train people working in the community outside of the healthcare model, who provide a lot of support for people living with Parkinson's and other neurological conditions? So training is the question. How do we train in medical school? And then how do we transfer some of that information to support group leaders and others who also need to establish relationships based on trust?
I'll let you go first.
Consuelo, I was going to say I was going to let you go first, because I feel like you probably deal with it.
All right. So, I actually think for medical students, we actually probably teach them how to not be trustworthy when they get to medical school. I think, they come in and they really, they're so altruistic and they care about everybody and they want to do the right things, and they want to spend a lot of time with the patients and the families, and then we sort of put them into these, organizations and systems, and sort of, teach them how to not communicate well, like, like use all of this, technical terminology, and don't appear too friendly or connected to people. And so I do think that at least on the medicine side, as physicians, we have to stop teaching students how to ignore some of the more human problems. Like we're so focused on the problem and the diagnosis that we're less focused on the person as a human being. And I think that we actually need to do more work ourselves in how we do that and how we more effectively communicate with people.
I think the reason I wanted Consuelo to go first was because I was going to say I feel like there's so much more that needs to be done. So it was like, can we start in a positive place? But I think it's a big gap. I think we need to do more of it. And I think one of the biggest pieces of it is that reflexivity of like, what am I bringing to the table? Like, what distrust am I bringing to the table? Like, what assumptions am I bringing to the table that is leading to a decline of sort of trust in this relationship? So yeah, I think we need to do better.
Yeah, and David, as far as outside of the health, the health system, and certainly social workers are not outside the health system, but often people who are working in communities and people who are those bridge builders or intersecting between the healthcare setting and outside. Again, probably are doing a lot of those things better than we're doing in medicine. They're communicating better, they're spending more time, they're making sure they understand an individual's circumstances and needs. And not all of that is just due to time. And so again, I think we as healthcare providers, especially as researchers, too, we don't listen to the story. We're not hearing what people are telling us.
Yeah. Well, I'm also thinking about programs that have really innovated the possibilities inherent in giving people who are already trusted sources of information in specific communities the tools to help others navigate health concerns. So providing, for example, health information in hair salons or at places of worship, so that people who already have established that trust and are turned to for information can have the information, public health information, then to give out. So there are many partners at play in building trust and making sure that people get the care that they need and deserve. So with that, we're going to wrap up this really fascinating and informative hour. I want to thank you both for your time, for your insight, your perspectives, your questions. I know we're at the beginning of this journey. Many institutions are at the beginning of this journey, but even the field of healthcare in general is really starting to ask the hard questions, and we all have work to do in figuring out how better to support and nurture our communities. So I'd like to thank you both for your time and for your expertise. I'd like to thank the Davis Phinney Foundation and Dance for PD program for partnering to host this series. Really want to encourage people to reach out to the Davis Phinney Foundation with additional questions or requests for this series. This series has developed through your input, and so if there are specific topics that you want to hear about and want to know more about, please let us know. As well, speaking of trust, if there are things that you really wanted to ask but didn't feel like this was a safe space for you to do that and would prefer to ask a question via email, you are welcome to do that to Jenna. And Jenna will put her email in the chat now so that you have that information. I also want to announce that our next webinar in this series will take place May 27th. Our guests are Nikde Mejia and Aswita Tan-Magrori. Stay tuned for more information about that on the Foundation website. I'll also remind you that a transcript for this presentation, as well as the video and audio recordings, will be distributed to you for reviewing or sharing. And I want to thank all of you today for joining us for this really important discussion and for asking wonderful questions that have have stimulated great conversation and thought. So thank you to all of our attendees for joining. Thank you to our expert guests for your insight, and we'll wrap it there. Thank you so much.
Thank you.
Thank you.